Hi, I'm Dr. Faisel Syed. Welcome to another episode of Faisel Friends. We're here because we believe everyone deserves access to quality primary care, and ChenMed needs physicians to take care of them. Exciting things are happening at Faisel Friends this year. Starting in February, we will no longer be going live on social media, but don't worry, you can find us wherever you listen to podcasts. Episodes will be available every Thursday. Tonight's topic is renal disease management in primary care. My co-host and moderator of the chat is Dr. Dan McCarter. Welcome, Dr. Dan.
Hey, Faisel. It's great to be with you again this evening.
It's great to be back again. We're back again live. How are you doing tonight?
I'm doing well.
I've really been enjoying this specialty series we've been doing, and tonight in particular, I'm really excited about having ChenMed's National Director of Nephrology joining us, Dr. Keda. Dr. Keda, welcome.
Hello, Faisel. Hey, Dr. Dan. How are you? Thank you for having me.
This is great. I mean, I feel so happy with the direction the company has been moving over the last couple of years. Now we've got access to so many specialists, and not even with the traditional consult where you have to put in a formal consult to reach out to your nephrologist for a nephrology question, but actually being able to text or even make a phone call, just a quick curbside. I mean, this is just an exciting time right now. I really feel like we're redefining the relationship between the doctors and patients, doctors and doctors, as well as the way doctors work with our staff. So thank you so much for joining us tonight.
My pleasure. My pleasure.
Dr. Keda, would love to hear your story about where you went to school, where you trained, and how did you end up coming to ChenMed?
So I'll pack it in as short as I can. So I immigrated from India about 20 years ago, and I was in South Carolina when I started my journey in United States. And the job I could find after months of searching was to be a dialysis technician in a rural clinic in a dialysis clinic in rural Georgia, which is a dialysis tech. It's kind of like a patient care tech. You're assisting the nurse with daily chores. The beauty of that job that I did for a year is the reason I am a nephrologist today.
Wow.
The experiences I had with the patient, being with them 12 hours a week, because they come for dialysis 3 days a week for 4 hours. So 12 hours of the experience, that the continuity of kind of care as well as relating and personally engaging, and I kind of enjoyed it. Elderly population, continuity of care, stories they would share. I just like, can I do this for full time? And they say, yeah, you can become a nephrologist and do this. And went to residency, and the day one of residency, I said, I want to be a nephrologist, and here I am.
Wow.
There are very few nephrologists, Faisal, in United States that who started their journey that way. But I'm privileged to be there because I'm maybe the few of them, if any, who can even string a dialysis machine. So if I used to get a call from the ER that a patient is crashing and they need urgent dialysis, I could show up and start the patient on dialysis even before my nurse comes in.
Wow. It's an incredible story how you came from India and you started your journey as a tech and then going and applying for residency and deciding so early on.
Yes, it was. And Medical College of Georgia in Augusta, Georgia has been my home for my residency and fellowship training. And thereafter, I kind of practiced in South Georgia, just, private practice experience for 12 years until I kind of fell in love with the value-based care. It took off in a kidney space in a small way. So I was doing it as a part-time thing, gaining skills for the last 5 to 7 years, participating in CMMI programs related to value-based care. And when ChenMed opportunity came along, it was no brainer for me. I was like, oh my gosh, I can do this 100% of the time and impact kidney care on such a large scale as big as ChenMed is. It's just beautiful. I mean, it was a no brainer, and here I am enjoying it, loving it.
Wow. Yeah, because what you were doing in Georgia and now the ability to be able to have an impact and connect with doctors in 12 states, at least up till now, and hopefully this year another 3 or 4 more will be in 15 or 16 states this year. So it's a really powerful ability to impact practicing primary care doctors and their patients. So What are your interactions like with the doctors?
Oh, well, let's do an example. So Friday, I got a call from our primary care doctor in Jacksonville. Right. This is an example that really opens a Pandora's box. What's broken with the kidney care nowadays? Um, our primary care physician calls me on Friday. Hey, Dr. Keda, I tried to send a patient to a nephrologist, and they're telling me send this patient now to the ER. I don't need to see him in the office. He needs to go to the hospital. I was like, okay, let's look at it. So I discussed with him the case. I looked at the labs and all that stuff. Everything can be managed outpatient on this guy. He is unfortunately closing in to starting dialysis. I mean, this is one of those issues. What we reflect is, inadequate preparation for dialysis issue. So he just never got all that things, all the ducks in the road to prepare and educate and plan for dialysis. And here he's needing to start dialysis, but he didn't need to start dialysis in the hospital. So I worked with the PCP on Friday. Then we caught up today, yesterday, Monday, Monday we caught up day before and did labs. I looked at the labs. We planned a visit with a nephrologist in Jacksonville, and I'm kind of assisting the PCP in delivering the right nephrology care. And here, this patient is going to probably start dialysis later this week in the outpatient setting in Jacksonville. Um, PCP is happy, patient is happy. I think that's
I've got to ask the question because in my prior life, I was attempting to run an ACO, and I, so for the life, I mean, tell me why in a country with what people would like to argue is some of the best healthcare, and I would say it probably is some of the best episodic healthcare in the world. Why do we have so many people crashing into dialysis? Why why did that nephrologist tell our PCP to send the patient to the emergency room in the middle of a pandemic, no less, when the patient could have been exposed to COVID, and even if fully immunized, a patient who's heading towards dialysis would be at pretty high risk. Boy, I think what you did is phenomenal. But why aren't all the nephrologists doing this? There's got to be a reason.
Yeah, Dr. Dan. So this problem actually takes root in the lack of innovation that is that's in kidney space. That is, we do not believe in the nephrology community that patients have ability to understand their disease state, converse about the disease, and participate in care, and they will do the right action to make, there's this mindset among nephrologists and the community that it's too difficult to educate a patient, prepare for dialysis, and it's become like, why waste energy behind something that we would not win the battle. And thereafter it's become somewhat of a tradition for the past decade or some over the decade that somebody needs to start dialysis, just send them to the hospital, and they will be what we call crash into dialysis. It's unfortunate that a country as advanced as we are, an 80% crash rate, 80% of the dialysis in this country is starting in this crash format.
But I guess it's safer if you go into the hospital and somebody puts a central line in, right?
It sure is.
I, I,
It is.
I'm just kidding, right? I mean,
It is.
you,
It is a good thing when it's needed. But I tell you, we can avoid this 99% of the time. Yeah,
but I mean, there's a big. I mean, you still get line infections with
you
those
do.
when you crash into dialysis. You get line infections. You get the risk of blood clots coming off the lines. Whereas if you
Mhm.
have the ability to put the access in and allow it to heal and be ready to use, isn't it much safer to do
It
that?
sure is. Having a arm access is anytime better than a dialysis catheter. The mortality in the first 3 to 4 months of starting dialysis is almost 50% less. So there's almost double survival with patient who has arm access than not have arm access. Dr. Dan, I'm going to add one more thing to it. Why are we failing so much is also, about 30 to 35% of the patients that starts dialysis have not seen a nephrologist ever. Now we can ask ourselves, so is it the fault of the nephrologist whom they've never seen? Or is it the fault of our system, healthcare system, that are we referring patients too late? Are we not talking about kidney disease with our patient? We got to ask ourselves in a broader sense.